Imagine a young woman waking up on an ordinary morning in 1952. She feels a persistent nausea, a fatigue she cannot explain, and notices her menstrual cycle is several weeks late. Unlike what would happen today, she does not go to a pharmacy to buy a pregnancy test. These tests simply did not exist for home use. She cannot search her symptoms on the internet, cannot call a medical helpline, and depending on where she lives and her financial situation, may not even have easy access to a doctor. Her first option is to wait. Wait a few more weeks, observe her own body, and perhaps speak quietly with her mother or a more experienced married friend. Pregnancy at that time began shrouded in uncertainty, silent expectation, and an almost total dependence on feminine intuition passed down from generation to generation. The 1950s in the United States represent a fascinating and complex period in the history of motherhood. World War II had ended just a few years earlier, and the country was experiencing what became known as the baby boom, an explosion of births that would shape an entire generation. Soldiers had returned from the battlefields, the American economy was growing at a rapid pace, and the ideal of the suburban family with a white picket fence, a dog in the yard, and several children was becoming the American dream par excellence. The fertility rate reached levels not seen since the beginning of the century, with women having an average of 3 to 4 children. Motherhood was not just a personal choice. It was practically a social obligation, a patriotic duty, the ultimate fulfillment expected of any respectable American woman. In this context, the experience of becoming pregnant and giving birth was undergoing significant transformations. Obstetric medicine was advancing rapidly, hospital births were becoming the norm rather than the exception, new technologies and medications were being introduced, and the role of doctors in the birth process was growing exponentially. At the same time, women had surprisingly little information and even less decision-making power over their own bodies and pregnancies. It was an era of paradoxes. Medical advances coexisted with practices that today seem outdated or even harmful. The celebration of motherhood coexisted with silence about the more difficult aspects of pregnancy, and women were simultaneously exalted as mothers and treated as passive patients who should follow medical orders without question. To truly understand what it was like to become pregnant in 1950, we need to immerse ourselves in this world of doctors' offices with ashtrays, women's magazines that taught how to keep the house spotless even with morning sickness, hospitals where husbands were forbidden from entering delivery rooms, and a society that had very specific expectations about how a pregnant woman should behave, dress, work or not work, and even how much weight she could gain. It was a world where pregnancy was treated almost like an illness that needed to be managed by specialists, but also as the most natural and desirable state for any married woman. Let us explore this journey from the moment a woman suspected she was pregnant to the birth of her baby, passing through doctors' offices, social expectations, hospital practices, and the deeply personal experiences that were rarely discussed in public. When a woman in 1950 suspected she was pregnant, her first step was usually to schedule an appointment with her family doctor or, if she had access, an obstetrician. The pregnancy test of that era was significantly different from anything we know today. The most common method was known as the Aschheim-Zondek test, developed in the 1920s, or its more recent variation, the Friedman test. Both involved injecting the woman's urine into animals, usually rabbits, mice, or frogs. The urine of a pregnant woman contains human chorionic gonadotropin, the HCG hormone, and when injected into a female animal, it caused detectable changes in its ovaries. The problem was that this test took several days to produce results, was expensive, and was not available everywhere. Many women, especially those in rural areas or of lower income, simply waited until the physical signs of pregnancy became evident, confirming through the changes in their own bodies what they had suspected for weeks. Once the pregnancy was confirmed, the woman entered a prenatal care regimen that, by current standards, was quite limited. Medical appointments were monthly during most of the pregnancy, becoming more frequent only in the final weeks. During these visits, the doctor checked the patient's weight, measured her blood pressure, listened to the baby's heartbeat with a Pinard stethoscope, a cone-shaped instrument that was pressed against the abdomen, and performed a basic physical examination. There were no ultrasounds. This technology would only begin to be used in obstetrics in the following decade and would not become routine until the 1970s and 1980s. This meant that the baby's sex remained a mystery until birth, as did much other information we now consider basic. Women pregnant with twins sometimes discovered this only during delivery. Fetal development problems were frequently not detected until it was too late for any intervention. The relationship between the pregnant woman and her doctor was marked by a power dynamic very particular to that era. Doctors, almost exclusively men, were seen as absolute authorities who should not be questioned. Women were discouraged from asking too many questions and frequently received little or no explanation about what was happening to their bodies. The phrase, "trust your doctor, he knows what's best," was repeated in offices, in women's magazines, and in conversations among friends. Many women described feeling infantilized during their prenatal appointments, treated more as containers for babies than as individuals with their own needs, concerns, and desires. Medical recommendations of the time reflected the knowledge and beliefs of the period, some of which we now know to be problematic or even dangerous. Weight control was an obsession. Women were instructed to gain no more than 15 to 20 pounds during the entire pregnancy, a guideline that today would be considered insufficient and potentially harmful. Doctors routinely prescribed amphetamines to help pregnant women control their appetite and keep their weight within established limits. These diet pills were seen as perfectly safe and were widely used, without anyone knowing the risks they posed to fetal development. Alcohol consumption during pregnancy was not discouraged the way it is today. Many doctors recommended a glass of wine or a beer to help pregnant women relax, and occasional cocktails at social events were considered perfectly acceptable. Fetal alcohol syndrome would only be identified and named in 1973, more than 2 decades later. Similarly, smoking was extremely common, and many doctors not only did not discourage the habit, but sometimes recommended it as a way to control stress and appetite. Photographs from the era show visibly pregnant women with cigarettes in hand, something that today would cause scandal, but was then completely normal and accepted. Pregnant women received specific instructions about physical activity, work, and social behavior. Exercise was generally discouraged, with the belief that pregnant women should rest as much as possible and avoid any effort that might disturb the baby. Driving was considered risky after a certain point in pregnancy. Working outside the home, when the woman had a job, usually meant hiding the pregnancy for as long as possible and then simply leaving the job, since there were no legally guaranteed maternity leaves and many employers fired employees as soon as they discovered they were pregnant. Discrimination against pregnant women in the workplace was legal and common. A pregnant woman's social life was also regulated by strict norms. There was an expectation that pregnant women would gradually withdraw from public life as the pregnancy progressed. Appearing at social events with a very visible belly was considered inappropriate in many circles. The fashion of the time reflected this attitude. Maternity clothes were designed to hide and minimize the belly, not to celebrate it. Skirts with expandable panels, loose blouses, and tent-shaped dresses were the norm, all designed to camouflage the pregnant body as much as possible. This expected discretion reflected a curious cultural ambivalence. Pregnancy was celebrated as a woman's noblest role, but the physical and bodily aspects of this condition were supposed to remain invisible and unmentioned in polite conversation. Pause for a second and tell me, what city are you watching this video from? And what rating from 0 to 10 would you give this story so far? Leave it in the comments. Preparation for childbirth in the 1950s was markedly different from today's approach. Childbirth preparation classes existed but were not the norm, and those that existed generally focused on teaching women to be cooperative patients who would follow medical instructions without question. Grantley, Dick Reed's natural childbirth preparation method, based on his 1944 book Childbirth Without Fear, was gaining some attention but was considered alternative and even controversial. Most women arrived at the hospital with little knowledge of what to expect from labor and delivery, depending entirely on the medical staff to guide them through the process. Hospital birth had become the dominant norm in the United States during the first half of the 20th century. In 1900, fewer than 5% of births occurred in hospitals. By 1950, that number had risen to approximately 90%. This change was driven by a combination of factors: medical advances that made hospitals safer places, public health campaigns that presented home birth as primitive and dangerous, and the increasing medicalization of pregnancy and birth. Midwives, who for centuries had attended most births, were gradually marginalized, their practices devalued in favor of male-dominated medical obstetrics. The experience of hospital birth in 1950 was profoundly institutionalized and standardized. When a woman arrived at the hospital in labor, she was immediately separated from her husband. Men were directed to waiting rooms where they would spend hours, sometimes an entire day or more, awaiting news. The idea of a father being present at the birth of his child was practically unthinkable. Childbirth was considered a medical procedure from which laypeople should be excluded, and male presence was seen as potentially disruptive, both to the medical staff and to the laboring woman. Once admitted, the woman was subjected to a series of preparation procedures that were routine at the time. Her pubic hair was completely shaved, a practice that supposedly reduced the risk of infection but actually had no solid scientific basis and frequently caused discomfort and irritation in the following days. An enema was administered to empty the bowels, another routine procedure that caused additional discomfort during an already difficult time. The woman was dressed in a standardized hospital gown, her personal belongings were stored, and she was taken to a labor room where she would remain, usually alone or with minimal supervision from nurses, until she was ready to give birth. The use of medications during childbirth was extensive and, in many cases, administered routinely without consulting the patient. One of the most controversial practices of the era was known as Twilight Sleep, a combination of morphine for pain and scopolamine to induce amnesia. Women under the effect of this medication remained semi-conscious during labor and frequently had no memory of the birth of their children. Scopolamine caused disorientation and agitation, and women under its effect sometimes thrashed and screamed, being then tied to beds with leather restraints for their own safety and to facilitate the work of the medical staff. They would wake up hours later with no recollection of what had happened, being presented with a clean, swaddled baby, as if the birth were an event that had occurred while they slept. Other forms of pain relief included general anesthesia, which left the woman completely unconscious during the birth, and regional anesthetic blocks. Epidural anesthesia, which today is the most common form of pain relief during childbirth, existed but was not widely used. The technology and techniques were still being refined. Many women simply accepted pain as an inevitable part of the process, especially those who did not have access to the most modern hospitals or who could not afford anesthesiology services. The birth itself was conducted in a highly interventionist manner. Episiotomy, a surgical cut made in the perineum to supposedly facilitate the baby's exit and prevent tears, was routinely performed on almost all women giving birth for the first time, and frequently on multiparous women as well. Doctors believed that a clean cut healed better than a natural tear, although later studies questioned this assumption. The use of forceps, metal instruments used to assist in extracting the baby, was common, especially when the woman was under the effect of medications that prevented her from pushing effectively. The standard position for delivery was lithotomy, with the woman lying on her back, legs elevated in stirrups, a position convenient for the doctor, but that works against gravity and can make the birth process more difficult. Alternative positions, such as squatting, kneeling, or on all fours, which can facilitate delivery, were not considered options in hospital settings. Control of the process was entirely in the hands of the medical staff, And the woman was a passive participant in an event that happened to her body, not something she actively did. The cesarean section rate in 1950 was significantly lower than today, standing at around 3 to 5% of births, compared to over 30% currently in many countries. However, when cesareans were performed, the risks were greater due to the technical and medical limitations of the era. Surgery was reserved for real emergency cases, and recovery was significantly longer and more difficult than today. After birth, mothers and babies were routinely separated. Newborns were taken to nurseries where they lay in rows of identical cribs, brought to mothers only at predetermined times for feeding. The idea of rooming in, with the baby staying in the room with the mother, was rare. Justifications for this separation included allowing the mother to rest, keeping babies in a controlled and sterile environment, and facilitating medical observation of newborns. But the result was that many mothers saw their babies only for brief periods during the first days of life. Breastfeeding, although it had been the historical norm for millennia, was in decline by the mid-20th century. Infant formulas were increasingly popular, presented as modern, scientific, and even superior to breast milk. Doctors frequently recommended bottle feeding, and infant formula companies marketed aggressively directly to healthcare professionals and mothers. Women who wanted to breastfeed frequently faced obstacles: separation from babies, rigid feeding schedules that did not respect the newborn's needs, and lack of adequate support and guidance. Those who had difficulties were quickly directed to formula without much attempt to resolve the problems. The experience of pregnancy and childbirth varied dramatically based on social class and race. Middle and upper class white women generally had access to private obstetricians, well-equipped hospitals, and private rooms. Poor women and black women frequently received care in overcrowded public clinics, charity hospitals, or wards where several laboring women shared the same space. Racial segregation was still law in many southern states, and even where it was not legally imposed, discrimination permeated the healthcare system. Hospitals that served black patients frequently had fewer resources, older equipment, and fewer qualified professionals. Maternal and infant mortality rates were significantly higher for black women than for white women, a disparity that reflected deep inequalities in access to healthcare, nutrition, housing conditions, and medical treatment. Black women were also more frequently subjected to procedures without adequate consent, and, in some documented cases, were used for medical experimentation without their knowledge or agreement. The story of Henrietta Lacks, whose cells were collected without permission in 1951 and became fundamental to medical research, is just one of the most well-known examples of a much broader practice. Women in rural areas face different challenges. Access to hospitals could mean journeys of hours on poor roads, and many women still gave birth at home, assisted by traditional midwives, family doctors who made house calls, or only with the help of family members. These women did not have access to modern medical interventions, which sometimes resulted in tragedies that could have been avoided in a hospital setting, but also meant they escaped some of the more controversial practices of institutionalized obstetrics. The question of informed consent, so central to contemporary medicine, was practically non-existent in 1950s obstetrics. Women were rarely consulted about their preferences or even informed about the procedures that would be performed on them. Decisions about medication, episiotomy, use of forceps, and other aspects of delivery were made by doctors, frequently without any discussion with the patient. Medical authority was practically absolute, and questioning the doctor's decisions was seen as inappropriate, even dangerous. Cases of abuse and neglect in the obstetric system of the era are difficult to quantify, but individual accounts suggest they were not rare. Women described being treated rudely, having their complaints of pain ignored, being reprimanded for screaming or moving during labor, and feeling profoundly dehumanized during what should be one of the most significant moments of their lives. These negative experiences were frequently minimized or dismissed. After all, what mattered was that mother and baby were alive and healthy, and any complaint about the treatment received was seen as ingratitude or weakness. Pregnancy outside of marriage carried a devastating stigma, In 1950s American society, unmarried women who became pregnant faced intense pressure to marry quickly, even if the relationship was not viable, or to give their babies up for adoption. Homes for unwed mothers, frequently run by religious organizations, housed pregnant young women who were sent away from their communities to hide the shameful pregnancy from their families. In these institutions, women frequently worked to pay for their stay, received little emotional care, and were strongly pressured to give up their babies. Many of these adoptions happened without truly free consent, with young mothers being coerced by families, social workers, and institution staff. Abortion was illegal in almost all states, with limited exceptions, generally only when the mother's life was in danger. Women who did not want or could not continue a pregnancy faced terrible choices. Some attempted to induce abortions on themselves using dangerous methods. Others resorted to illegal practitioners, risking serious infections, uterine perforations, and death. Statistics from the era are imprecise precisely because illegality kept many cases in the shadows, but it is estimated that hundreds of thousands of illegal abortions occurred annually, and thousands of women died or suffered serious complications as a result. Women with financial resources had more options, including traveling to countries where the procedure was legal or paying doctors who performed abortions discreetly. Poor women frequently faced the greatest risks. The postpartum period also had its own norms and expectations. Hospital stay time after birth was significantly longer than today, frequently a week or more for uncomplicated vaginal deliveries. When she finally returned home, the new mother was expected to immediately assume all care of the baby and the household, frequently without much support beyond occasional visits from family members. Postpartum depression was not recognized as a legitimate medical condition. Women who struggled emotionally after birth were frequently seen as weak, ungrateful, or inadequate for motherhood. Throughout the 1950s and in the following decades, gradual changes began to reshape the experience of pregnancy and childbirth. The natural childbirth movement gained strength, with women questioning the need for so much medical intervention and medication. Books like Marjorie Carmel's Thank You, Dr. Lamaze, published in 1959, introduced ideas about childbirth preparation and active participation of women in the process that were revolutionary for the time. Breastfeeding support groups, like the La Leche League founded in 1956, began to offer alternatives to conventional medical advice and create support networks among mothers. The 1960s would see the beginning of more significant changes. The birth control pill, approved in 1960, would give women unprecedented control over their fertility. The second wave feminist movement would begin to fundamentally question power structures in medicine and demand that women have an active voice in decisions about their own bodies. Hospitals would begin, slowly, to allow fathers to attend births. The routine practices of shaving, enemas, and episiotomy would begin to be questioned. Twilight sleep would gradually fall out of use as its problems became better known. In the 1970s, the Supreme Court decision in Roe v. Wade would legalize abortion nationally, radically transforming the options available to women with unwanted pregnancies. Alternative birth centers and the assisted home birth movement would gain strength as alternatives to conventional hospital birth. Ultrasound would become more common, offering a window into the womb that previous generations never had. Breastfeeding rates, which had reached their lowest point around 1970, would begin to recover as the benefits of breast milk were rediscovered and promoted. Each of these changes represented battles fought by women, progressive healthcare professionals, and activists who refused to accept the status quo. Women who gave birth in 1950 could not imagine many of the options their daughters and granddaughters would have. But it was their experiences, their frequently untold stories, their silenced frustrations, and their small resistances that planted the seeds for the transformations to come. Now that you know this entire story, tell me, what city are you watching from? What rating from 0 to 10 do you give this video? And more importantly, what do you think about this? Leave your opinion in the comments. I want to know your perspective on this topic. Pregnancy in 1950 was an experience shaped by forces that went far beyond the biological. It was defined by medical norms that treated birth as a pathological condition to be managed by specialists, by social expectations that positioned motherhood as a woman's supreme destiny while silencing their real experiences, by class and race inequalities that determined who received dignified care and who was left on the margins, and by a power dynamic that concentrated decisions in the hands of male doctors, while women were relegated to the role of passive patients. Looking at this history allows us to see how much has changed and how much certain issues remain relevant. Debates about the role of technology in childbirth, about the balance between medical safety and women's autonomy, about racial inequalities in maternal health outcomes, about the value of informed consent and active patient participation in their own medical decisions. All these themes have deep roots in the experiences of millions of women who became pregnant, gave birth, and became mothers in an era that seems both distant and strangely familiar. The women of 1950 navigated a system that offered promises of modernity and safety while frequently leaving them without voice, without information, and without control. They found ways to create community among themselves, to pass knowledge from mother to daughter, to quietly question when they could not question aloud. Their stories, for so long considered too mundane to be recorded, reveal important truths about how societies treat those who bring new lives into the world. The journey of motherhood is always deeply personal, but it never exists in a vacuum. It is shaped by medicine, by law, by culture, by economics, by available technology, and by the power relations of each era. Understanding what it was like to become pregnant in 1950 is understanding a specific moment in this constantly evolving history, a moment that influenced everything that came after and continues to echo in the conversations we have today about birth, motherhood, and bodily autonomy. The decisions made in delivery rooms, doctors' offices, hospital boardrooms, and congressional corridors during that decade shaped generations. The women who lived these experiences, who survived births under twilight sleep with no memory of the birth of their children, who were separated from their babies by rigid hospital rules, who hid pregnancies in homes for unwed mothers, who risked their lives in illegal abortions, who simply did the best they could with the options they had. These women are part of a story that belongs to all of us. It is a story of silent resistance, of adaptation, of love that persists despite circumstances, and of gradual transformation that opened paths to different experiences. In reflecting on this era, we are invited to consider not only the past, but also the present and the future. Each generation inherits a system and has the opportunity to question it, maintain it, or transform it. The women of 1950 inherited a system and did what they could within it. And in doing so, many began to plant the seeds of change that their daughters and granddaughters would harvest. It is a story that has no definitive ending because it is still being written in every doctor's office, in every delivery room, in every conversation about what it means to bring a new life into the world and who should have power over that process.